We put that in is because we gave this presentation first in Italy and Rome. So obviously I wanted to give individuals, when we were talking about what we were talking about, there was a lot of international guests, and I wanted to give them an idea of the backdrop to the research. So we thought we would highlight it first of all with the National Anthem, which always gives me goosebumps, and also to show them all the pictures of the disparity and the differences within the Western Cape. So that's why you got to enjoy that rendition of Nkosi Sikelele with some visuals. So the background to the study really is that cervical cancer, and so I'm taking this as a case study, but an important case study, and the paper is about to be published, so hopefully I'll be able to give you a copy at some point if you're interested in reading further. But the background to the study is that cervical cancer is the second most common cancer amongst South African women. There has been some debate around this, whether breast cancer is the first or the second. Sometimes they say that cervical cancer may actually be the first, the most common cancer among South African women, and that about 5,927 women a year, and again that's rough statistics, are diagnosed with the cancer, but obviously many more may actually have cervical cancer. And they say of those that are diagnosed, probably about 53% of these women actually die. Now the reason this is a concern is because cervical cancer is a very easy cancer to prevent. If individuals go for an abnormal, for a cervical screening and they receive an abnormal pap smear, it's very easy to just cut out the little abnormal cells and for the person then to be basically treated. And those abnormal cells won't go on to becoming cancerous cells. But because of the lack of adherence to screening, a lot of women don't actually go through this procedure. One of the other things that we've started to learn is that the human papillomavirus, I don't know if any of you are aware of the human papillomavirus. Anyone know about the HPV virus? Okay, a few people. So the human papillomavirus has been found to be a precursor to cancer. They say in about 63% of the cases, HPV virus is a precursor to, has been found in individuals who develop cervical cancer. And what this means really is because the HPV virus is actually carried by about, they say about 21% of South African women. Now 21%, that's only of the women. Men can also carry it, but we're obviously looking at women with cervical cancer. So thinking 21%, think about that. That's a fifth of women, where potentially in 63% of the cases, if the stats are correct, could go on to develop cervical cancer. The human papillomavirus is an STI, or it's considered to be an STI, but they're not 100% sure that it's always transmitted sexually and how it comes about in the first instance. And individuals, obviously, when they have HPV, generally are symptomless. Particularly men, women as well, they might have a bit of bleeding and, of course, eventually may develop abnormal cells in their cervix, but generally it's symptomless, so you wouldn't know. You could have HPV and you actually just would not know. And you could not know for years, and you could carry it for years and nothing could come of it, or you may end up developing abnormalities in your cervix, and then those go on to cancerous cells. Also, the problem with HPV is they've also found this, of course, with HIV, is that women who have cervical cancer and HPV tend to develop a more invasive, aggressive cervical cancer. So it develops a lot faster. The period of progression can be about 20 months, which for a cancer is very quick. That's less than 2 years. Okay, obviously with individuals who have HIV, it's also rapid, much more rapid progression because your immune functioning is a lot lower. The other thing that's important with cervical cancer is that the prevalence of cervical cancer is much higher in black South African women, amongst all the ethnic groups, black South African women, and they say that about 1 every 34 black South African women will develop cervical cancer, or the sort of abnormalities to cervical cancer. So that's about 1/3 of black South African women. We also know, of course, that black South African women are the most likely to live in poverty. So that's important to know, and in severe poverty. So there may be a link there. We've obviously spoken about that with social inequalities and economic inequalities compared to what other ethnic precursors or factors may exist. So I've spoken a little bit about progression, treatment, severity. Obviously, the reason, and unfortunately it often comes down to money. Sometimes it is about care and nurture, and I think a lot of the time healthcare is, but a lot of the time it's also down to economics. And what actually happens is that typically with cancer, prevention is a lot cheaper often than treatment, most of the time. And of course the costs of suffering is terrible with cancer, particularly with cervical cancer, which is often heavily stigmatized in certain cultures because of the way it progresses in the body. So the suffering's terrible with this, and the severity can be awful, and of course severity often ends up with death, so it's a very severe disease. And the cost of treating the cancer, when you think about the person losing their jobs, not being able to possibly care for families, having other people who may need to caretake them, and the actual medical treatment, the costs are very, very high. And they've done a study, about a 3-year study, a couple of times, and they found that if women who've never attended screening before, ever attended screening, just attend a 3-year screening program, they can reduce the incidence of cervical cancer by 60 to 90%. 60 to 90%. Huge. So it's important, really, and this is why we ended up doing this research, to discover why. Why is it that women don't go for screening? Because if they do go for screening, look at what the outcome could be. 60 to 90% reduction. That's huge when you think that the severity of the disease is that you could end up dead. HPV virus, we're still learning a lot about it, so I'm going to I'm not a medical expert, so I'm tentatively putting this out there. They have found a link in some research. The initial research, unfortunately, that was done with the HPV virus, people were very skeptical. I remember learning about it in my master's in London, and what they first just demonstrated there was a link. But what happened is then they discovered that all the research, if you traced it back, had been backed by huge medical companies who were then selling the vaccine to countries in bulk. So of course immediately people said, no, hang on a second, this is all rubbish, they're playing with the statistics, they're creating links for economic reasons and then selling, you know, cargo loads of vaccines to countries saying you must be vaccinated against this virus. So for a while that research stagnated, people were very skeptical. And then what happened is now again they started to show links. But it is quite a controversial area because we don't really understand the HPV virus, where it comes from in the first place, and sometimes they will find people who maybe have been sexually never been active who may carry it. It's very rare, but it can happen. So again, it's not something we understand fully, and I don't want you to become alarmed because, I mean, a high percentage of the population do carry it, but it's not, regular screening can easily prevent. And sometimes, if you've got a very, again, I'm tentatively putting this out there because I'm not a medical expert, but they have said that if you have a very strong immune system, so for example, you don't have HIV, well, not HIV that's managed well, you can have good immune functioning, but AIDS. If you have AIDS, unfortunately, something like the HPV virus, your body can't fight it. Most of the time, our bodies fight it. So that it actually doesn't often show up if you were screened for it, because it's so negligible in the body. Because a high percentage carry it doesn't mean that everyone's necessarily going to experience the effects of it. But we are living in a country where there is a high HIV and AIDS prevalence, and as you've seen the stats about 2 weeks ago. So obviously a large percentage of the population where we're finding this kind of cancer with HPV, there's also another very powerful disease behind that which often impairs immune functioning. So the body, because we have cancerous cells in our body all the time, do you know that? And our immune functioning is good enough that we're able to fight those constantly. So our little leukocytes and all the red blood cells are being activated, the white blood cells are running around, and doing their job. But when you have very impaired immune functioning, this is when a lot of these issues can become a problem. But screening, regular screening can help and can obviously prevent individuals dying of this illness. The issue mainly with this, of course, then, speaking about all of that, is that only 13.6% approximately of women in South Africa actually attend screening regularly. 13.6% attend regular screening. So previously, when they looked at adherence, they spoke about the adherence factors. This is in other research, not our research. Previous research showing that knowledge was a big factor in whether or not women attended screening, adhered to screening. Language also, and language being important because often if somebody's foreign to a country or doesn't speak the dominant language of the country particularly well, a lot of the knowledge would be conveyed in that language, or practitioners would work in that language, and that could be an issue with adherence. Cultural beliefs and attitudes, very important factor. Provider characteristics and manner, and that's about the practitioner or the healthcare system, and we'll talk about these more when we talk about seeking healthcare treatment and adherence to that. Fear and anxiety, of course, it's very important. A lot of people won't go for screening for certain tests because of fear and anxiety, and we can understand this. So if you're fearful of obviously attending screening or any kind of checkup, it can prevent you from attending. Or if, dentists, I always think of dentists with this. And a lot of people not going to have, they might have a little pain in their tooth and they think, I actually can't bear it. I can't go. So they won't go until they basically need a root canal procedure or their entire tooth pulled because they're absolutely terrified of the dentist. For whatever reason, I think a lot of us might have childhood memories of horrific dentists who might have been extracting teeth. We might have watched, I don't know if you've ever seen Little Shop of Horrors. It's a very old movie, but there we go. That frightened me of dentists for life. So fear and anxiety, very important component. And obviously service accessibility. If it's not very accessible for you to attend a service, you most likely won't be attending as often. So if you live in a remote area where there's virtually no clinics, or if you're working and you have to take a day's leave to go and sit in a long queue in a waiting room and wait for a doctor, there's a good chance you'll put off going for screening. So what about South Africa? All of you, I hope, by now are familiar with the health belief model. And I know that I, in those Flip the Classroom, said, you know, models and theories can be useful, but they're not that useful because only 40% prediction. If you think about it, human beings are hugely unpredictable creatures. So 40% of prediction is actually quite high. It's not always 40% prediction power, but it's actually quite high. Because there's so many variables we have to try and control for that are unpredictable within our wider environments, our more micro environments, and of course within the individual themselves. So the models can be useful, and they can be even more useful if you do what we did, which we think was explore them qualitatively. So often they're explored quantitatively. There's numbers that are turned into statistics and then predictive powers and variables that are calculated to show how powerful the model is. We took each of the variables of the health belief model and we spoke about it in a qualitative fashion with our participants. So we recognized that the health belief model had identified a number of factors which are possibly very, very useful. So some of those, and we spoke about them when the second group of you were creating your models, demographic variables and psychological characteristics of individuals. And those are precursors added to, sometimes they're added to the health belief model. They're not always present. And the others, of course, are perceived severity, which hopefully you understand and know about by now, perceived susceptibility, how susceptible am I? Am I somebody who may get this illness, or am I somebody who may not? If, for example, you have breast cancer in your family, you may be aware of the fact or feel more susceptible to breast cancer than if you don't. If you're a heavy smoker, you may think later on in life, sometimes when you're young you don't think about it yet, although you may, think I'm more susceptible to lung cancer. Costs and benefits, and that's the costs and benefits of doing the behavior or not doing the behavior. Cues to action. Cues to action are things often like symptoms. So you may experience, if you were a heavy smoker, you'd start shortness of breath, coughing a lot, or if you just suddenly experience extreme pain in your back which goes on and on and on, that's a cue to action. You're then more likely to go and either adopt a health behavior or go for screening or treatment, which is also considered a health behavior. Health motivation, of course, how motivated are you around your health? Very important, because some people will often say, I don't really care about my health. And often to some extent they don't. I remember I had a peer, for whatever reason, and again it's very complex, but I had a peer who was suffering from diabetes, and he never really took precautions. So unfortunately by the age of 40 he had both his legs amputated, and by 45 he had died of the illness. And for some reason, no matter how much his friends spoke to him about this, he didn't want to engage with the idea that he had this chronic ill health condition that needed to be treated or managed. So in terms of his health motivation with regards to that, with regards to other things it may have been different, but with regards to that, he was not very motivated to look after his health. And perceived control, again, is about whether you perceive that you're able to carry out the behavior or not. Is it within your control? So eating fresh fruit and vegetables, is it a possibility for you if you have nowhere, even vaguely close to where you live or work, that provides this? And you may think, well, I have no control of this, I just can't access it. Maybe your country's at civil war and you actually can't access certain foodstuffs, certain sanitation products, etc. So you may forget about doing that behavior and think, well, I can't right now, it's completely out of my control. There may be other factors, of course, which might be around self-esteem, where you just don't believe that you personally are able to do something, to exact some kind of change. But that's more linked with self-efficacy, and they're closely interlinked, but they're not exactly the same thing. So what we did, and it's interesting because I was looking at this study the other day and I thought, I'm not quite sure why now we put knowledge. I know our reasoning at the time, but having watched some of you present on your models, and I was thinking about the different models, we put the factors into three categories. So we looked at barriers, facilitators, and then knowledge for some reason we popped on its own. And actually, when I look at it, I think knowledge could have probably fallen under barriers and facilitators, because it can be, some knowledge can be useful in facilitating screening adherence. Some knowledge can be absolutely terrifying or create resistance in someone, and they might think, there's no way in hell I'm going to get screened. So that could be a barrier. But in this study, we looked at them because knowledge seemed to spring out so powerfully as a factor, we took it as a separate factor. And then we had barriers and facilitators. And if you look at the barriers, these were the ones we identified, structural and psychosociocultural, and then facilitators being information sources in our physical state, and the knowledge being knowledge about disease risk, view of cervical cancer, and knowledge about pap smears or cervical smears. So, these were some of the structural barriers, and I'm just going to, remember we did these in focus groups. So we got a whole lot of women who lived in the communities of Masiphumelele and Red Hill. Masiphumelele being out near Kommetjie, for those of you familiar with the Western Cape, and Red Hill being a little settlement on the side of a mountain near Simonstown, Fishhook area. So we went to these two settlements, and we spoke to groups of women about some of the barriers and facilitators, just getting them to discuss what they knew about cervical screening and why they may or may not have attended cervical screening themselves. So we've taken it verbatim out of the qualitative research, and the researcher here is asking, okay, why did you decide not to go for a pap smear? When you heard about it at the clinic, why didn't you? And in terms of time, this is one of the quotes. Of course, this is just an example of what some of the women said, because there are many. She says, I never get the chance to go to the clinic because I'm always working. And that was time. And we're talking about time constraints because a lot of these women were from disadvantaged communities. So earning an income was often quite difficult. Getting a job was often quite difficult. And if they had a job, if they were working, they were definitely not going to ask for a whole day, which often meant going without pay, to go off and sit in a clinic. And a lot of this government services meant they would have to sit in long queues for 5-6 hours to attend a screening session. One of the age factors was, they spoke about this. This was actually a very new, I didn't know this because I came back to South Africa a few years ago, and I wasn't aware at the time, although apparently they've moved it in the UK as well to 25 years of age. But I didn't realize that in South Africa, and this was something I learned during this research, is that you have to be 30 to receive free screening. You have to be at least 30 years of age. So you get one free screening at the age of 30, one at 40, and one at 50. The only time you receive free screening prior to 30 is if you have physical symptoms, for example, extreme pain, abdominal pain or bleeding, or you are HIV positive. And we'll talk about the complications of that in a moment. So, P1 said, participant 1 that is, I did, but they said I'm underage. They said you must have a 30. Okay. And then health education, very important because a lot of women felt that they didn't have the kind of health education that was required for knowing about when to go for screening, why it was important, and what could be done if they were told then they had some abnormal cells. No one goes and gives us that information that you have to go. So they didn't necessarily understand what screening was about. Some of the psychosocial cultural was fear, as we spoke about. An example of fear was, I was scared, I didn't watch others because I didn't know. I was quite scared because I didn't know what was going to go on. And you know it's your private part and you feel uncomfortable and it's quite scary. But when you've done it, it wasn't that bad or uncomfortable. So again, a lot of women didn't really understand what it was about. And of course, it is, you know, it can be quite an embarrassing kind of screening for a lot of women. Not only obviously women from this community, but women right across the board will experience it as quite invasive, intrusive, and you have to go in and discuss some things that you may not wish to discuss with anyone, never mind be so vulnerable in front of a practitioner. So fear, again, important. And fear, as we will discuss in a moment, also speaks to many other types of screening or treatment procedures. Feelings. I'm feeling uncomfortable because we are scared of the people. Okay. When we explored that, a lot of the time it was they were scared of the practitioners. I know one of the women said to me, and I'm painting a bit of a negative view right now of the practitioner, but it's not that all practitioners are like this, but one of them said, we go to the clinic and some of the nurses have said to us, why must we be scared? If we are coming for the screening, we're obviously used to opening our legs. And obviously, after that was said to this young woman, she said to me, well, I don't want to go back. I feel very judged. I'm going for screening, and it upset me, so I'd rather not go. So that's when she said, I feel scared of the kind of judgment that may occur. The thoughts, and these were some of the thoughts about, remember these are barriers, some of the thoughts about what actually this means for the person within their community, because they're psychosocial cultural barriers. Yes, people's going to say about you when you go there, I feel fine because I don't care what they say. So some people said, I don't really care, and that wasn't a huge barrier. And others said, yes, I'm worried about what people are going to say. Often what we found out as well with cervical screening, because one, it's got to do with the genital area, and it might be, well, a lot of the women said it's associated with STIs. And as soon as you in South Africa make extrapolation from STI to HIV. So unfortunately, a lot of the screening also happened in clinics which were predominantly used by patients who were HIV positive. And because there's such stigma around HIV, a lot of individuals said, I don't want to go into that clinic because there's an assumption about why I'm going there. Of course, a lot of the women who were going in for screening were HIV positive because they can have frequent free screening on the government health services if you are HIV positive, because they recognize that your immune functioning is very low and that you're more likely to have invasive treatment. Information sources, very quickly then, were facilitators. So sometimes they said, from formal sources, I don't understand cervical cancer, I want to know about it, yeah. I'm hearing it on the radio or on TV at the clinic, whatever. But I don't know about it, I want to know about it. So there were some formal sources where women found out about cervical cancer and cervical screening and then decided they wanted to know more. Informal sources were more about word of mouth and how it spread. My cousin's sister had the breast cancer and she's still alive. They cut my sister's breast and she's still got a hole on her breast. What we found when we often spoke to the women is that they put all cancers together. So they often, when we were speaking about cervical cancer and when we've done future research, further research, they would often speak about other cancers as well, particularly breast cancer. That came up a lot. And of course there's a big fear about that, because what happened to a lot of the women that they'd known with breast cancer is that they were disfigured because of the surgery, often having a double mastectomy or a huge part of their breast cut out, and then they would think cancer, and that would be immediately what they associated cancer with. And that was very frightening for them. In terms of facilitators, physical state, And again, these you will see when we talk about it in a moment, often are also facilitators for many other health behaviors or seeking health behavior sort of screening and treatment adherence, but for many population groups. This is how they came out in this particular discussion, and we were looking at the health belief model, but they can be shown to be present. So physical state is the presence of negative symptoms. If individuals actually have symptoms, they're more likely to go for screening. Of course, because they become worried and they think there's something wrong, especially if there's pain, they go for screening. And the relief of negative symptoms. What we found is that in many of the clinics, they will actually treat individuals for pain or discomfort. So even though they're doing a screening procedure, if there's something else within the cervix that they discover or in the vagina, they will quickly treat it. They don't always explain this to the patient. So or if they do, the patient maybe misunderstands. So sometimes they think, that was great, I went for screening and I'm absolutely fine. No, now I have no pain. And so they will often be more motivated to go for screening when they have these physical symptoms because they associate that with some kind of symptom relief and treatment. And as this woman said, I often got stomach pains as well, but it all stopped after pap smears. Presence of another physical illness, of course, a big motivator, HIV. A lot of women would attend because of that. And desire to know one's health status. So for me, it works because I do get the results back. I get to see whether I have cancer or anything wrong with my womb. And then knowledge, where knowledge about the risk, very importantly, as I said, this could have been a barrier or a facilitator. Knowledge could actually be put into both or either of those categories, but we found it to be quite powerful and it emerged constantly, so we decided to put it as a theme by itself. I think cervical cancer sometimes is the transmission of the disease, is going to sleep with another. A lady is roaming about. The lady sometimes has got the infection. Not to go to the clinic, I think, can make the cancer. So you can see some of the beliefs about how you become at risk. Some women spoke about if you don't eat enough fruit and vegetables, you become at risk. Drinking a lot of beer, you can also become at risk. This person's speaking about if the lady is roaming about, which implies the woman, she was speaking about a woman being, having multiple partners. And also saying if you don't go to the clinic, you get the cancer. The view of cervical cancer was also very important. If they do find it in any part of the body, there's no cure for it. You die when they have found the cure too late. So there's quite a big fear, and that's important because if people don't understand that it's very, very easy to treat, what happens is they think if they find it, it's a death sentence. And that prevented some women from going. They thought if they find anything, and it's not only in this population group. Often if you speak of the word cancer, people immediately become very anxious about it because often they will think that's it. Cancer, as they call it, the big C, it's a death sentence. So there's no cure. And knowledge about pap smears, when they're talking about, I stopped having hip pains after doing pap smears. I often got stomach pains as well, but it all stopped after pap smears. And why we put this into knowledge is because women often made the mistake of linking or associating different things. They didn't really understand what a pap smear was about. So again, because it was symptom relief, and they'd go, well, I had hip pains, and now I don't have hip pains. It may have been that there was some of, but generally a cluster of abnormal cells won't create pain in your body. But there may have been other STIs, or they may have treated them or given them other painkillers. So often what would happen is it would be an all-in-one. The woman would go to the clinic and they'd be treated for some other things, and that wasn't always explained, and they also went for screening, and they would associate the two as being part of cervical screening. And then these were just some of the recommendations we made about the future studies and what we needed to do. So we decided community members could be facilitators, and actually train, and they often do now, train some of the women to actually train each other then about and promote knowledge within the community and talk about the screening, go for screening themselves and talk about it. The difficulties we obviously faced in the study, one was the language. We did often have it also being spoken, and we had to try and translate as best we could. We did have one or two of the women who were helpful in translating, and obviously we translate the transcripts. Some of the women spoke in English, but in future I think it would be much more powerful to use also women to actually maybe hold the focus group. And we spoke about being outsiders. So in research, often it's quite difficult. This is quite a sensitive topic to come in and talk about when you don't know the woman. So in future, we thought if you spend time, you deliver some training, you become known as somebody who's around, and not just arriving at somebody's home and expecting a whole lot of women to talk about a very sensitive topic. It can be difficult, and often people are reluctant, especially in a group with each other, as well as, again, with foreigners, or outsiders, I shouldn't say foreigners, but foreigners to the community.